Hi everyone, welcome to your online lecture for the course Pathophysiology 1. In today's lecture we're covering inflammation and immunity alterations. This slide shows you the topics or the themes that we're going to be covering today, with the exception of immunodeficiencies, which we'll be looking at when we talk about AIDS. But these are the 5 main topics that will be covered when speaking about inflammation and immunity alterations. We'll start with inflammation. The human body is continually exposed to a large variety of conditions that could result in damage. And this damage can be at the level of a single cell, which maybe can be repaired. But when damage is done to multiple cells, to entire tissues, or an organ, then disease can result. And we know that disease can lead to death. So to protect us from these conditions, the body has developed this very highly sophisticated, multi-level system of interactive defense mechanisms, that of which we can collectively call our immunity. And so this slide makes you aware of this multi-level system, which includes 3 lines of defense. We have our first line of defense, which is really our natural barriers, both physical and mechanical, biochemical barriers as well, and just even our normal microbiome that's present within our body, within areas such as the digestive tract, within the vagina in females, for example. We have our second line of defense, which includes inflammation, and that's really going to be what most of today's lecture focuses on. And then our third line of defense is not part of our innate immunity, so we could say that these guys are part of our innate immunity, so this would be our natural inborn immunity, whereas our third line of defense is adaptive or acquired, meaning that it comes with time. When we're exposed to certain things, our body adapts and acquires immunity to it. Now we'll talk about the inflammatory response and some of the major features that are involved. Inflammation will be activated by virtually any injury to vascularized tissue. So in other words, if there's an injury to tissue that has a blood supply, then an inflammatory process will be activated. So before we begin talking about that, it's important to understand what the classic or cardinal signs of acute inflammation are. And they're listed up here on the screen as erythema, which is redness, heat, swelling, and pain. These are probably things you could have come up with very easily yourself if I asked you. And these have been around forever, for a very long time, and have been known as the classical signs of an inflammatory response. But what was kind of added in later is loss of function. So when there is injury to an area, it's not functioning as it should. A few other details: inflammatory response is considered very quick. It happens much faster than, say, our third line of defense, which involves our acquired immunity. Inflammatory response, unlike acquired immunity, is non-specific. And what that means is that it really just happens the same way every single time, whereas acquired immunity is more of a specific reaction. And it's mostly localized, and that's actually one of its important features when it comes to an inflammatory response. Is we want the inflammatory response to be localized, and if it's not localized and it spreads to healthy, uninjured tissue, then it could cause damage. So making sure that it's confined to the area is very important. As we'll see today, this process of inflammation is mediated by both inflammatory cells and chemical mediators. We'll go into details on these shortly. And what are the goals, or what are some of the benefits, or what's the purpose really of inflammation? Well, one, to neutralize and limit the cause of tissue injury. And remember, again, we want to make sure that we can confine the inflammatory response to a particular area that's injured. We want to also clean it up. So this is done by the process of phagocytosis. So cleaning up injured tissue, cleaning up dead cells, cleaning up pathogens, for example, and then also to promote healing and repair. So if we compare the this normal image to one that's representing inflammation, you can see some of the things that are occurring. And an important feature is called vasodilation. And you can see that happening when you look at normal compared to inflamed, that vasodilation has occurred. And vasodilation is just an increase in the size of blood vessels. And what this does is it allows for a slower blood velocity, meaning blood flow in terms of speed slows down, and so this will increase blood flow to that affected area where vasodilation is occurring. There is also going to be an increase in the presence of fluid within the interstitial spaces, so edema. So we're going to have leakage of the plasma proteins, and we're going to see an influx of white blood cells, and neutrophils is really the one that we're going to be focusing on today. So they're recruited to the area, and then they migrate to that area. And so you can see very clearly the presence of many more of these white blood cells in an inflamed tissue, at an inflamed tissue site, compared to the much fewer you would see normally. Because we do have what we call resident lymphocytes or resident macrophages that kind of just live in the tissue. And then in the event that there is some sort of injury, then we're going to get an influx of and the recruitment of many more. On this slide, you can see some of the different inflammatory and immune cells that are involved in processes that will have to occur after injury. And these should all be familiar to you. We have neutrophils. Their main goal, as even the name suggests, is to neutralize the area and also to destroy. They have the ability to phagocytose. We have monocytes that also have the ability to phagocytose, and monocytes, when they're recruited to a tissue, will develop into macrophages, which you can almost think of as being these giant monocytes that are involved in inflammation and immunity. We have eosinophils. These are primarily involved in allergic responses. And we have lymphocytes that are involved in immunity, but more specifically, they're involved in our acquired or adaptive immunity, which we'll talk about towards the end of the lecture. So recall B cells and T cells. And looking at this histological sample, you can see the presence of granules in the cytoplasm. And these granules are going to contain substances that can be released when degranulation occurs. And these will also come up later on. So let's look at some of the main events of inflammation. As part of an inflammatory response, one of the things we'll see is called increased capillary permeability, meaning that the capillaries become more permeable. And we've talked about this before when we spoke about edema. So the capillaries then become more porous. And so what ends up happening, or I should say the reason that they become more porous, is because the endothelial cells that line the blood vessels will retract and they'll pull apart. And this will allow for plasma to move through. This will allow for cells to move through. And you can see that happening here. This retraction is very evident. And it allows for the easy passage of, let's say, white blood cells into the area of injury. Let's say this is the area of injury. You can see the separation here as well that allows for what's called transudate. Transudate is a fluid that's pushed through the capillary due to higher pressure within that area of the capillary. We're also going to see immigration of neutrophils. And neutrophils are really the first cell to arrive, so to travel to the area and arrive there. They travel in the bloodstream. And then once they get to the area of injury, they start to get more sticky. They release an adhesive substance that allows them to become more sticky, and they'll stick more to the vessel wall. So they'll kind of get stuck in this region, which is good because then they can migrate into the tissue itself. Now, how does a neutrophil know where the injury is? Well, something called chemotactic factors are released at the area of injury. And these chemotactic factors are going to be attractive to the neutrophils. The neutrophils and even other cells later on are going to be attracted to this area in order to complete their role of really cleanup. And chemotactic factors, for example, are released by macrophages that reside in the area. So macrophages that are, you can consider them to be residents of the area, will release chemotactic factors, which you can think of them as sort of like a flag that's telling the neutrophils where they need to go. You can also see, we'll talk about this a little bit later, but that mast cells degranulate. You can see the presence of platelet aggregation. You can see the fibrin threads that are starting to form there in order to form a clot. This slide shows a little bit more about what we have just spoken about. So let's look at an example of a splinter, which you've probably all experienced at some point. So if you have a splinter within your skin, macrophages are activated in that area. So again, those resident macrophages are activated and they'll begin to phagocytose any bacteria or, let's say, pathogens that are present in that area or that have entered via the splinter. And so the macrophages are going to release chemotactic factors that will attract neutrophils to the area, but they will also cause the vessels to dilate and to allow for the passage of substances through the endothelial, in between the endothelial cells. And one of the main goals of these neutrophils, as I already mentioned, is to neutralize and to clean up. If we look down at this image here, you can see a little bit about how this recognition and attachment of bacteria or other pathogens happens. And what you can see here is a bacteria that has been identified by another cell because of receptors that are present, and you can see it starting to engulf it. Once it recognizes it, it binds to it and it starts to engulf it. And so then if we look at this image here, showing you the actual process of phagocytosis, we have this phagocyte that has already identified the bacteria and bound to it, and it's going to now begin the process of phagocytosis. So it engulfs it, it brings it into the cell, it's going to form what's called a phagosome, and then lysosomes that are present within the cell are going to now bind to it as well, creating what's called a phagolysosome. And then what we have here is the actual destruction and digestion of that pathogen so that it's no longer a problem. There's a term I'd like you to be aware of called opsonization. And what will happen with, let's say, a bacteria that's present in the area is part of the inflammatory response is going to opsonize the pathogen, and it sort of means that it's coating it with something that makes it more attractive for phagocytes. So it coats it with a substance, opsonizes it, and this really makes the phagocyte want to be attracted to it, want to eat it and digest it. And then after all is said and done, the cells that are in the area that have cleaned up the mess are also going to begin to clean up the mess that they've left themselves. Let's now talk about some of the chemicals that mediate inflammation. On an earlier slide, I said that chemical mediators are very important in inflammation. We'll talk about the main ones. We spoke about vasodilation and we spoke about vascular permeability as being involved in inflammation when there is an injury. So what causes this vasodilation to occur? Well, a few different things. We have prostaglandins, and those are local hormones, if you remember from anatomy and physiology. They also vasodilation also occurs because of the release of histamine, which is released from granules when they degranulate, and nitric oxide as well. In terms of vascular permeability, which really is that endothelial retraction, this is permitted also by histamine, by bradykinin, by leukotrienes. And PAF, which is platelet activating factor, which is really a pro-inflammatory mediator in inflammation. In addition, moving on to the arrows now, the first arrow talks about pain. And what actually causes pain when we experience something such as an injury or a splinter? Well, prostaglandins, once again, are involved, those local hormones, but they interact with bradykinin, and bradykinin contributes as well to the development of pain, and it's really because it makes nerve endings more sensitive. In terms of systemic effect, a fever oftentimes, or depending on the situation, will result, but what causes the fever, promotes it, are interleukins. So interleukin 1 and interleukin 6, as well as tumor necrosis factor alpha, and once again, prostaglandins. So you can see how much prostaglandins so far in terms of vasodilation, pain, and fever are involved. And sometimes when you're sick, you might consider taking, for example, aspirin, and aspirin will block the production of prostaglandin, which will then reduce the amount of vasodilation, the amount of pain, and the fever that the person would otherwise experience. And how it works in terms of their development of a fever is these substances will be released by activated macrophages, and they end up traveling to the brain, and they turn up the body temperature. So remember that the hypothalamus is really our body's thermostat. And what this ultimately does is cause enzymes to decrease in function in our body. So the fever is going to cause enzymes, normal enzymatic reactions, to reduce in function, and that's because we know that enzymes need a particular body temperature to function in. And so the body's really told to slow down its metabolic processes. On the right side of the screen here, I've kind of want you to zone in on the angiogenic factors. One of the purposes of inflammation is to help the body heal, as we've already introduced. And angiogenesis is the generation of new blood vessels. So angio is referring to blood vessels, genic is the formation of. And one of the factors that will come up again is called VEGF, which stands for vascular endothelial growth factors. And these are very important for healing. We need to form new blood vessels so that we can have new healthy tissue. So in other words, it's very important for healing, these angiogenic factors. And to the bottom of the slide here, we have TNF alpha, or tumor necrosis factor alpha, and beta. These factors here cause phagocytosis, and if this mechanism is exaggerated, it can lead to major problems within the body, but this will be discussed in Patho 2. And you can see the increase in macrophages and cytokines and the overall increase in phagocytosis. Okay, let's talk about the acute inflammatory response, and we will also talk about the chronic inflammatory response, so it will be important for you to compare and contrast both. Now, in the event that there's been cellular injury and maybe there was pathogenic invasion, we would expect to see mast cell degranulation. So we're going to be looking at this image here. So cellular injury, pathogenic invasion, we would expect to see mast cell degranulation. And mast cells contain histamine within their cytoplasmic granules. So when they degranulate, they release their histamine. We'll also see what's called the activation of these plasma systems. So this involves a complement system, a clotting system, and a kinin system. Clotting, another term for this then, is coagulation. And these systems are activated, as well as a number of different plasma proteins that are produced in the liver. And then this here is showing you the release of cellular products from cells. Now, in terms of what results we get from this, vasodilation, this is going to cause redness and warmth. We're going to see vascular permeability. Remember, with vascular permeability, it's going to lead to edema or interstitial swelling. You'll see the infiltration of cells that will eventually lead to the formation of pus, or what is called a purulent exudate. The part of this clotting pathway is going to produce clots. And then stimulation of nerve endings, and this is what leads to pain. And remember, we talked about prostaglandins and bradykinins being involved in that production of pain. This bottom slide here shows you the 3 different systems that I just spoke about that are involved in inflammation. So these 3 here are summarized in this slide here just in terms of their purpose. So the complement system, when activated, this can destroy pathogens directly using what's called a membrane attack complex that we'll talk about a little bit later. The coagulation system is that clotting system, which has the ability when you form a clot to trap microbes and foreign bodies and also prevent spread, right? Keeping everything confined so that healthy tissue isn't affected. And then the activation of the kinin system, this involves bradykinin as one of the final products, and bradykinin working with prostaglandins will lead to the pain that we feel because of the stimulation of the nerve endings. But the kinin system is also involved in vasodilation as well as increased capillary permeability, as we've spoken about many times already. Well, let's look at the chronic inflammatory response now. So superficially, the difference between acute and chronic inflammation is duration, and that's just looking at it superficially. And chronic inflammation generally happens once you've reached maybe the 2-week mark or longer, and it can last 2 weeks or longer as well, regardless of what the cause is. Chronic inflammation is sometimes preceded by maybe an unsuccessful acute inflammatory response. So for example, if a bacteria contaminates a tissue, or let's say a foreign object persists within an area or in a wound, then an acute response may end up being prolonged and beyond 2 weeks. And this is where we get into more of a chronic inflammatory response. And some examples of why this might happen, well, you could have maybe a microorganism that has cell walls that are very thick and it make it very difficult for phagocytes to phagocytose them. Maybe microorganisms have the ability to survive inside of a macrophagy. Other microorganisms will produce toxins that damage tissue, which cause persistent inflammation that could lead to a chronic inflammatory response, just as an example. Chronic inflammation is characterized by a dense infiltration of lymphocytes. So when we talk about lymphocytes, now we're speaking about the chronic inflammatory response because we originally had many neutrophils and macrophages in the area, but when we get to a chronic inflammatory state, we start to see death of these neutrophils, and the neutrophils actually become part of any pus formation in the area, or that purulent exudate, as I mentioned earlier. And so we'll see, in addition, fibroblast activation. And fibroblasts are cells that are found in connective tissue, and they produce collagen as well as other fibers. Lymphocytes are going to be working hard to recruit even more monocytes to the area so that when those monocytes arrive, they'll eventually become macrophages. So here's that recruitment that I'm speaking of. And the fibroblasts will be working to try and repair the area, possibly wall off the area of inflammation. And what we can see is either the tissue repairs back to normal or it forms a permanent scar. And we'll look at a couple of examples of this on an upcoming slide. So still talking about the chronic inflammatory state, if macrophages are unable to protect the host from tissue damage, so in other words, the acute inflammatory response was not successful, then a granuloma may form. And this is your body's attempt to wall off and isolate the infected area, forming what's called a granuloma. A granuloma is a mass of granulation tissue, typically produced in response to infection or inflammation or even the presence of just a foreign object, such as a splinter in the area. And what its purpose is to isolate the area. So it's formed by lymphocytes that surround the inflamed area. It then becomes encapsulated by fibrous collagen. And then with time, it can become cartilaginous or even calcified. Something else that we'll be seeing is that macrophages in the area can fuse together. And when they fuse together, they can form what's called a Langerhans giant cell, or sometimes it's called just a giant cell, and it's multinucleated, and it has the ability to engulf very large particles, so larger than those engulfed by a single macrophage. But this process of granuloma formation is really important when it comes to TB or tuberculosis, especially chronic tuberculosis. So just to summarize this chart here, when there's cellular injury, we talked about the acute inflammatory response, and if all goes well, then the area will end up being healed. But if it persists, we'll end up with chronic inflammation. From there, it could heal. If it doesn't, then, and macrophages are really unable, and the lymphocytes are unable to protect the host, then a granuloma forms. And we talked about that and the important features in the gray box. And then it would be healing at that point, but left with likely some sort of cartilaginous or calcified marking. Okay, let's move on to our next topic, which is wound healing. On this image you can see, or this graph, you can see the different phases of wound healing. It kind of summarizes the different phases, and you can see that one of the first things that happens with wound healing is coagulation. And the coagulation, you can see, happens very quickly, but you can also see that it doesn't last for very long. The next phase we have is inflammation, and we just spent a lot of time talking about inflammation. From there, we have the proliferation of new tissues phase, and then we have remodeling and maturation. And you can see some of the different cells that are involved throughout this entire process, from injury to the point of healing. Platelets being involved right in the beginning. We spoke a lot about neutrophils, especially in acute inflammatory states. Then we spoke about lymphocytes as we progress to more of a chronic state, the introduction of fibroblasts, which are involved in helping with the actual healing process. And then we also spoke about those macrophages, ones that are resident to the area and then ones that are recruited to the area initially as monocytes. You can also see that there's a lot of overlap too between these phases. They overlap with each other. There are two different types of wound repair depending on severity. We have primary intention and secondary intention. And when a wound heals by primary intention, as this slide discusses, the wound is really considered small, or maybe it's been sutured and the borders have been approximated, so the borders are close together. So this is a much simpler process. In an ideal world, wounds heal by primary intention. So looking at each of the individual images here, within what we're going to be seeing is clot formation. So the fibrin clot forms, just pointing out some of the main features. In B, we're going to be seeing the activation of these inflammatory cells, neutrophils, macrophages, etc. We've spoken about this already. So this is our acute inflammatory stage. And now on to wound healing. This is where collagen formation occurs from those fibroblasts that are present. Fibroblasts really fill the area with collagen, helping to make that tissue strong like it once was. And then eventually formation of a scar. And it doesn't necessarily mean that this individual is going to be left with some major marking. It just means that this new tissue has formed and the area has healed. And the severity of the scar, of course, will depend on the severity of the initial injury. So this is what we hope happens, that the edges were nicely approximated together and we have as best of healing as possible. Secondary intention occurs when the wound is too big, or maybe it wasn't sutured together, so the edges were not approximated, but they should have been. Skipping past the acute inflammatory stage, the first one, we're going to be looking now at the formation of new blood vessels. So this is an important feature when it comes to wounds healing by secondary intention. And this is mediated by, remember we talked about the vascular endothelial growth factor, or VEGF, and this allows for angiogenesis, or the formation of new blood vessels. And these blood vessels develop from the underlying dermis. The body attempts to really bring nutrients and other cells to the area to help regenerate and repair the wound. Granulation tissue will begin to form. This is during the reconstructing phase. And granulation tissue is a combination of new blood vessels and fibroblasts in the area. Down here at the bottom, we can see that there's the closing from the bottom up, and you can actually see that with these arrows here. We're closing from the bottom up. But you can see the collagen fibers are being formed, so collagen synthesis, and you start to get contraction of the wound, so the moving closer together, and then new epithelial tissue forms and closes it off. But when it comes to formation of an actual scar, so scar tissue, capillaries disappear because the scar tissue is avascular. This image here shows you a hypertrophic, so that's a term that you're familiar with, a hypertrophic scar, and a keloid scar. This is really more of a dysfunctional wound healing, where there's been excessive collagen synthesis and excessive deposition of the collagen. So let's move on to adaptive immunity. Remember, this is also known as acquired immunity. This is our third line of defense. This is where we have very specific responses to an antigen that comes into our body. And so this is different than what we talked about with inflammation, where it's non-specific. The same thing happens all the time regardless of a cause. But with adaptive immunity, it's very specific to whatever antigen is coming into the body. So you can think of adaptive immunity as the body adapting to antigens that present themselves to it. So let's look at some of the lymphoid tissues. We've reviewed this in normal anatomy and physiology. But where is our immune system? Well, it's found within lymphoid tissue. And the slide summarizes the different areas that lymphoid tissue is found. It's not just within our lymph nodes. So lymphoid tissue is where you'll find a lot of lymphocytes present. And these cells mediate our immune system. Remember, these are the lymphocytes T and B, so B and T cells, or B lymphocytes and T lymphocytes. But we have our tonsils. Remember, we spoke about tonsils including pharyngeal tonsils, palatine tonsils, your lingual tonsils. We have the thymus, which starts to get a lot smaller after childhood. We have Peyer's patches. These are found within the intestinal tract, so they're patches of lymphoid tissue. Our bone marrow is involved in our immunity. Lymph nodes that are present in all different areas of our body. And our spleen. This is a big one. Our spleen is a big lymphoid organ that helps a lot with our immunity. So let's have a look at an overview of our immune response. And some of these terms will be familiar to you from anatomy and physiology, but we have really two main responses: B cell responses and T cell responses, which I'll highlight here. Now remember, all blood cells are produced initially in bone marrow. They don't always mature in bone marrow, but they're produced there. And so when we produce a lymphoid stem cell, so in other words, a cell that is destined to be a lymphatic cell, part of our immune system, some of them are going to migrate to the thymus to mature. Those are our T cells. The B cells B for B cell, B for bone, these are going to be maturing within the bone marrow. And then after they've matured, T cells are going to migrate to the spleen where they spend a lot of their time. And B cells, there's some in the spleen, but they're going to migrate to lymph nodes once they've matured. T cell immunity is also known as cellular immunity, and that should make more sense shortly. And B cell immunity is also known as humoral immunity. When T cells are activated by some sort of antigen, they're going to travel, or I should say produce, these subpopulations of T cells, which you can see here. So subpopulations of T cells. And this is why it's called cellular immunity, because of the production of these subpopulations of T cells in response to the presentation of an antigen within the body. Now, B cells, when activated, so after they've matured, they end up, for the most part, in our lymph nodes. When they're activated, they're going to become plasma cells. And these plasma cells are going to produce antibodies that are specific to a particular antigen. Let's talk for a minute now about helper T cells, or TH cells. If an antigen binds to a cell that's called an APC, also known as an antigen presenting cell, the antigen presenting cell will then present, just as the name suggests, the antigen to the helper T cell. This will then cause the activation of two different groups of memory cells. We have T memory cells and B memory cells. And memory cells, just as the name says, are going to be involved in this specific response because it will have a memory of what happened. And then the last thing to mention, humoral immunity, what that means is that humoral refers to fluids, whereas with cellular immunity, it refers to the production of a variety of different cells. This slide here shows you how humoral immunity works. So we're talking about the B cells or the B lymphocytes. If someone is exposed to an antigen, so here's the first exposure, they will end up getting a primary response. This will involve the production of two main antibodies, immunoglobulin M and immunoglobulin G. And these antibodies, these IgM and IgG, are very specific to the antigen that it was exposed to. And then so what happens if you're exposed to that same antigen another time is you get this exaggerated response, in particular of IgG. And this can be applied to even vaccinations. So when somebody gets a vaccination, they'll develop an immune response to it, but then should they be exposed to it again, they get a much more exaggerated immune response. So why is it good to have antibodies? Well, we have both direct and indirect functions. Without antibodies, so starting with the first slide here, without antibodies, the virus can bind right to cells and become problematic. But with antibodies, so the Ys that you can see here represent antibodies. If these are present, they can bind to the virus, creating this specific immune reaction to facilitate phagocytosis of that virus. And so this can be called virus neutralization, trying to neutralize the viruses that are present. Another example would be toxin neutralization. So bacteria have the ability to produce these toxins that can be very damaging to the body. Antibodies that are present in your blood can actually help neutralize these toxins before they become a problem, because if they attach themselves to cells, then they can infect the cells and create many issues. An example of this, of a bacteria that can can cause toxins that are problematic is tetanus, for example. Next up, we have complement-mediated killing. Whenever an antibody binds to an antigen, then a complement system gets activated. And there's different pathways that can activate it. This is an example of the classical pathway activating the complement system. And this involves a series of different plasma proteins that are involved in this response. And these proteins, as I mentioned earlier, are produced in the liver. So when activated, the end result really is the production of MAC, which stands for membrane attack complex, which I mentioned on an earlier slide. And membrane attack complex can bind itself to the wall of a bacteria and cause the puncturing of the wall. So it almost punches holes within the bacteria. And this happens until the membrane has been attacked enough that the cell is badly damaged. And in the fourth example here of indirect function of antibodies, macrophages phagocytosa bacteria. And we spoke about the process of opsonization earlier, in which an antibody can bind to a bacteria, coat it, allowing it to be more attractive for the process of phagocytosis. So let's move on to our last topic now, where we'll talk about different types of hypersensitivity. The definition, which I'm just going to read right off the slide, of hypersensitivity is an altered immunologic response to an antigen that results in disease or damage to the individual. So you can think of it as our immune system overreacting, hence the term hyper. It's very hypersensitive. So what happens is the antigen comes, the immune system overreacts and ends up causing damage to the body. And there's 4 types. And the upcoming slides have images of each, and I'll speak about some of the relevant, or at least relevant to you for this course, details of each. But your textbook can be used as an additional resource for you to further clarify, or maybe get a description in a different manner that helps you learn. So we've got type 1, which is called IgE-mediated hypersensitivity. Type 2 is tissue-specific. Type 3 is immune complex-mediated. And type 4 is cell-mediated. Type 1 hypersensitivity is defined by the participation of immunoglobulin E, so IgE. This is very important in allergies, but I don't want you to just associate type 1 hypersensitivity with allergies. But in this case, there are certain type of allergies. For example, a bee sting is a type 1 hypersensitivity reaction. But the example that we're going to go through in this diagram here involves pollen. So we have pollen in the air that's breathed into the respiratory tract. It, as you can see in this image, it's reaching the level of the respiratory epithelium. The antigens from this pollen are detected by cells. For example, this cell here is a type of antigen presenting cell called a dendritic cell, and you can see the dendritic extensions on it. And this cell is going to present the antigen to, in this case, a T cell receptor. So at this point, the T cells have been stimulated. And when the T cells are stimulated, the TH cells, or the helper T cells, are stimulated, they end up presenting the antigen then to B cells. So it's almost like the passing of a baton, passing of the antigen, presenting it to one another. And one of the things that the B cell is going to do then is produce antibodies, IgE being a big one. Now, what IgE will end up doing is binding to mast cells. So you can see there's the IgE antibody. It's binding to a mast cell. When it binds to a mast cell, and actually also eosinophils, it can bind to, it causes them to degranulate. And when they degranulate, you can see that happening here, you end up with the release of their constituents, of the granules. So for example, histamine. And so this will cause symptoms that you would experience during allergies, such as maybe swelling, smooth muscle spasms, mucus secretion. So in the case of pollen being breathed in, the person will produce mucus. The person will get swelling within their respiratory tract. They'll even get smooth muscle spasms, and this can be very dangerous depending on how sensitive somebody is. So it could make potentially breathing very difficult. And so you can see some of the effects: edema, the smooth muscle spasming, infiltration of leukocytes in the area, and vasodilation, mucus secretion, etc. This is showing you what happens when the eosinophil releases histamine from its granules. Now, histamine, think of histamine as creating a lot of the symptoms that you experience when you have some degree of an allergic reaction. And what do you do when you have some degree of allergic reaction? Well, sometimes to help the symptoms, you take an antihistamine to prevent the formation of a lot of the symptoms that become very comfortable. And in individuals that experience more extreme reactions, if they get too many spasms and maybe they're having difficult breathing, then an EpiPen with epinephrine might be needed. You can see here some of the contents of granules. So we'll start with we have primary mediators and secondary mediators. Histamine, proteases, and chemotactic factors are released in degranulation, and then leukotrienes and prostaglandins as part of a secondary mediation. Now, when it comes to, say, exposure to an environmental allergen that causes this IgE production, repeated exposure to the antigen is usually required to elicit enough IgE so that a person becomes so-called sensitized and they become hypersensitive. In other words, the first time a person's exposed, their reaction may be a lot less than the second time, then the third time, and so on and so forth. Type 2 hypersensitivity is also known as tissue-specific hypersensitivity reaction. These type of reactions are generally against a specific cell or a tissue. Cells express a variety of different antigens on their surface, some of which are called tissue-specific antigens because they're expressed on the plasma membrane of only certain cells. So that's tissue-specific. So for an example, if a person is given a blood transfusion and they're given the wrong blood type, the foreign red blood cell in this person's body will be detected by, specifically, IgM antibodies, which will then bind to the antigen on the red blood cell and activate this whole complement system, including the production of the MAC, or the membrane attack complex, which ends up puncturing holes within that red blood cell because it's considered foreign, and it ends up leading to lysis or hemolysis of that red blood cell. And this can be very dangerous for an individual that suffers from it. So this type of example is a complement-mediated lysis, so activation of the complement system. And when you see numbers letters and numbers like this, it's referring to the components of the complement system, which produces the production of plasma proteins. Another example that I'd like you to be aware of type 2 hypersensitivity reaction involves hemolytic disease of the newborn. That's something that we're not going to go through in this lecture, but remember that means that if a woman is pregnant with her first baby and that baby has a different blood type, the mother will, remember we talked about the Rh negative and Rh positive, the mother can produce antibodies after that baby is born, which can be problematic for a second pregnancy where the mother has the antibodies that could attack that baby. So that's hemolytic disease of the newborn. Now on to the third type, which is immune complex mediated hypersensitivity reaction. When an antibody, so that's represented by the Y, binds to an antigen, it forms what's called an immune complex. So this is an example of a small immune complex. And they combined with other antibodies and form a bigger, they can bind with other immune complexes and form a larger immune complex. And so these can be circulating in the body and then deposit themselves in certain tissues. And most type 3 hypersensitivity reactions are caused by this antigen-antibody complex that forms and then later deposits itself into the walls of tissues, sometimes even to the walls of blood vessels. There's a primary difference between type 2 and type 3 mechanisms. Or hypersensitivities. Type 2, from the last slide, type 2 hypersensitivity involves an antibody binding to an antigen on the cell surface. Whereas with type 3, the antibody binds to an antigen that you can think of as being kind of soluble in the blood or within body fluids and forms a complex which is then later deposited into the tissues. Type 3 reactions are not considered organ-specific, and symptoms are mostly unrelated to the particular antigenic target of the antibody. So in other words, the symptoms are not necessarily going to be related to the antigen itself, but rather the complex that forms and the location that it deposits itself. And so here you can see the deposition into a tissue. Now, the harmful effects of these immune complex depositions are caused by complement activation, particularly through the generation of chemotactic factors in the area. So all of a sudden you have all these chemotactic factors that are being given off in the area, and what they end up doing is attracting neutrophils, because we know neutrophils will be attracted to an area by the presence of chemotactic factors, or by the presence of them. Phagocytosis will be attempted in the area, but it's generally unsuccessful. And you end up with large quantities of lysosomal enzymes being released at this site instead of contained within the phagolysosome or within the phagocyte, as discussed on an earlier slide. And so we end up with tissue damage to the area because all these neutrophils come in, and then you get them trying to phagocytose, but they're unsuccessful, and then they release a lot of their lysosomal enzymes, which are very powerful digestive enzymes. And so you can see that neutrophils, this neutrophil chemotaxis is neutrophils being attracted to an area where chemotactic factors are present, and neutrophils adhere to the area. They start to degranulate. We end up with lysosomes in the area, ultimately causing destruction and damage to that tissue. And lastly, an example of a type 3 immune complex mediated hypersensitivity reaction is lupus. Now on to our final type of hypersensitivity reaction, and also the final slide for today, is the cell-mediated hypersensitivity reaction. And this is mediated by T cells. Cytotoxic T cells destroy other cells that are called target cells by binding to it. And you can see that happening here. Now, this actually happens in, for example, graft rejection. So a graft is a piece of living tissue that is transplanted surgically. And if rejection happens, this can be a type of cell-mediated hypersensitivity reaction where you get, for instance, the cytotoxic T cells that end up binding to another cell or a target cell, let's say on a transplant, and almost trying to kill it and get rid of it. Now, what sort of events happen? Well, you get the production when this event occurs, you get the production of granzymes and they're a type of enzyme. And they induce programmed cell death by the target cell. You also get the production of a protein called perforins, and perforins will try to perforate the cell to try to kill it. The cytotoxic T cell will really ultimately try to cause apoptosis of the target cell. So it could be a graft that's being rejected. And you also get the activation of macrophages, which are involved in trying to destroy that target cell. And lastly, the helper T cells are involved to, as their name says, to help. And they're involved in producing cytokines. They're trying to recruit and activate these phagocytic cells that participate in the reaction. But at the end, what ends up happening is destruction of tissue. And when it comes to grafts, that's a problem and quite a concern. And another example of this would be somebody being exposed to poison ivy. And this type of reaction, the type 4 cell-mediated hypersensitivity, is oftentimes called, or sometimes called, a delayed type of hypersensitivity. And the reason for that is because the tissue reaction, so in this case, let's say a graft, whether it's a kidney or let's say your skin that has been exposed to poison ivy, the reaction usually occurs anywhere from 24 to 48 hours after exposure to that antigen. So that's all there is for this lecture. Thank you for listening.